Good morning. Welcome to the plenary session of the National League for Nursing's 2011 Educational Summit, Leading Academic Progression, Advancing the Health of the Nation. It is indeed a privilege to begin this session by bestowing the NLN President's Award for an enduring legacy in nursing education on Dr. Billy J. Brown. Internationally recognized as a leader in education and administration, Dr. Brown has been at the forefront of nursing for more than 30 years through her achievements as both dean and professor at the University of Texas at Austin School of Nursing and as president of several of nursing's most distinguished professional organizations. At the University of Texas at Austin, Dr. Brown was a dean and professor of the school for 17 years, serving earlier as assistant and associate dean. In fact, she was the founding dean of the School of Nursing. Dr. Brown's visionary approach to teaching and administration led to her appointment as the La Quinta Motor Inn's Centennial Professor in 1983, and her induction into the Hall of Fame at the University of Texas School of Nursing at Galveston in 1992. Her numerous professional awards and honors include being named Nurse of the Year by the Texas Nurses Association and resolutions passed by the State of Texas Senate and House of Representatives acknowledging her contributions to nursing. And if you've been following politics, you know how hard that is to get through those two bodies. At the national and international level, she's widely respected for her service as both president of the American Association of Colleges of Nursing and Sigma Theta Tau International. As chairman of the fundraising task force for Sigma Theta Tau International, she led a successful multi-year campaign that produced more than $7 million in planned gifts, which was huge for fundraising for nursing at that time. In 1999, Sigma Theta Tau selected Dr. Brown for its Mary Toll Wright Award for Excellence in Leadership and announced the formation of the Billy Brown Society to pay homage for her dedication to plan-giving efforts that contribute to the advancement of scholarly nursing. She was recognized with the Nell J. Watts Lifetime Achievement Award in Nursing at the 2007 Sigma Theta Tau Biennial Convention. A fellow of the American Academy of Nursing since 1984, in November 2002, the Academy presented her with the President's Award for her support of the original Magnet Hospital research. And in 2010, Dr. Brown was named a living legend for her extraordinary and sustained contributions to nursing and healthcare throughout her career. During the Living Legend ceremony, Dr. Angela McBride, who had nominated Billy for this extraordinary award, described her as a leader of leaders. To quote Dr. McBride, Billy did not just hold the position of president of AACN, Sigma Theta Tau, and the Texas Nurses Association. Billy facilitated the growth of these organizations, leading them into new directions. Dr. Brown graduated from nursing school at Arkansas Baptist Hospital in Little Rock. She received her bachelor's degree in nursing from the University of Texas Medical Branch School of Nursing at Galveston. She earned her master's degree in nursing from St. Louis University and a doctor of education from Baylor University in Waco, Texas. The theme of our summit this year is leading change. I can think of no one who better exemplifies the art of leading change to reshape nursing education and the organizations of nursing. Dr. Brown has built an enduring legacy of innovative and inspirational models. She has, through those models, moved nursing and nursing education forward. Please welcome and honor and acknowledge our colleague, Dr. Billy Brown. There you go. Let's get out from here and come over. Yes. There are only a few times in one's life you get pictures like this, and we want her to have a great one. Got it? I can help you with that. Got it? There are others? Congrats, Polly. I can hold it for you. Yes? Oh, yes. You're next. Glad to do that.
Thank you. Thank you, Kathy. And I asked her if I could say just a word, and I promised not to say too many words because I know the schedule is tight.
Let me help you with this.
It's a real...
I'll stand.
I feel very honored to be given this award, especially by two of the people that I've worked with so many years and have admired so many years, both Kathy and Beverly. And they are two of my dearest friends, and it's especially rewarding to me to be given this by you, Kathy. Thank you. Thank you. I've known Kathy since she was a long time. The one thing I want to say that I doubt that even Kathy knows is my history with National League for Nursing. When I graduated from Baptist Hospital in 1947, the director of the school was Mary Toll Wright. Now that name will be familiar to many of you. She was one of the founders of Sigma Theta Tau. When we graduated from Baptist Hospital School of Nursing, she said to us, there are two organizations that you have to belong to. When you graduate, you must belong to this. I will not approve you for graduation until I'm sure you're going to. One is the National League for Nursing Education, and I have been a member since that time. I think one year I took out because I didn't think I had the money to pay it. But beyond that, and the American Nurses Association. So it's been my privilege to be a member of the National League for Nursing for all of those years, and I'm a very proud member, and I'm especially proud to be given this award. Thank you. Thank you, Kathy.
He didn't get one, okay. We've got to do it. You want it this way? We've got to do another picture. He didn't get one. Hold on. We can do this. Let's move away from here. You can do what you want. We'll hold it there. Yeah, it's beautiful. Here you go.
Thank you both.
Mm-hmm. Oops, colleague there. One more. Thank you. I think it's an admirer. Thank you. It's an honor to acknowledge someone who's given so much to nursing and nursing education and done that so generously to so many people. And now it's my privilege to ask the members of our esteemed panel to come to the stage. Once we've taken all of our seats on the stage, I will introduce them. And if they would come at this time. There we go. Hi, Linda. Love it. Love it. You got it? So you want some water? Yeah. Babe up? You're good. Okay. Got to get everybody comfortable up here. This is one of our, we love doing these. These are our interactive sessions. And you'll always be amazed at what is said with when you have leaders on stage who can speak from their hearts and interact with you. So once we do some of the initial presentations, which will be short, we want you to be engaged with us at the mic, so be prepared for that. And it's now my pleasure to introduce our panel members. To my far right is Teen Hansen Turton, CEO of the National Nursing Centers Consortium Executive Director of Convenient Care Association, and Vice President of the Philadelphia Health Management Corporation. Under Teen's leadership, the Philadelphia-based National Nursing Centers Consortium, a professional association of community-based health centers, has grown from 11 regional health centers to more than 200 centers throughout the country, employing nurses in a wide variety of roles, serving more than 2.5 vulnerable people. Teen has also been instrumental in positioning nurse practitioners as primary health care providers, particularly through her work in the Convenient Care Association. Next to Teen is Cami Monarch, Chief Operating Officer of the Nurse Family Partnership, this is a nurse-led nonprofit organization addressing the needs of low-income first-time parents and their children. Cami leads the Nurse Family Partnership practice, program development, and program quality support teams at the national office in Denver. Nurse Family Partnership's evidence-based model of partnering nurses and first-time moms has more than 30 years of research from randomized controlled trials that prove it works. The Nurse Family Partnership National Service Office provides training and support services to ensure that the model is precisely replicated in communities, leading to improved outcomes for both mothers and children. To my left is Dr. Linda Norman, a Senior Associate Dean for Academics at Vanderbilt School of Nursing in Nashville, Tennessee. Too numerous to mention now, Linda has been involved in many innovative projects while at Vanderbilt. But today, she will highlight her work to bring interdisciplinary education to Vanderbilt in Tennessee and talk about an innovative model that builds collaborative practice between multiple disciplines and community settings. And of course, to Linda's left is Dr. Beverly Malone, CEO of the NLN and my partner over the last 2 years in all things NLN. Bev needs no further introduction. Last evening, we had the pleasure of listening to Dr. Donna Shalala, who gave a passionate, informed tribute to nurses as leaders in healthcare, and also an overview of IOM, the background, the report that has meant so much to the nation, which is the future of nursing. She articulated patient-centered care, interdisciplinary, accessible and affordable, and quality care with improved health outcomes. Accomplishing that mandate in light of the changing profile of this population in our country and the healthcare landscape requires us to have a fundamental shift in care delivery and expanding the numbers of advanced practice nurses. We had to talk too about expanding the scope of practice available to all types of nurses. Our intent today is, by highlighting these emerging innovative programs, is to consider how nurses are currently leading new models of healthcare delivery and how our collective curricula will need to change in light of these innovations. To begin, I will ask each member of the panel to briefly describe their innovation, explaining how it is cutting edge and how it creates leadership opportunities for nurses from all types of programs in light of the IOM recommendations. And I'm going to start with Linda because I know she has a lot to say, and I'd like you to start this, please.
Okay. Well, thank you for the opportunity to come and share the story of what we're doing at Vanderbilt with interprofessional education. We started this idea of figuring out what we wanted to do with a different model of education for, first, it was medicine and nursing. Those are the two disciplines that are represented on our campus. And then we looked at, we really need to be able to influence and work with other professions because the team wasn't complete with only having the School of Nursing and the School of Medicine. And I will have to say, I feel like I'm missing a partner here. My other partner in crime is Dr. Bonnie Miller, who's our Senior Associate Dean for Academics in the School of Medicine, and I have to say we have been joined at the hip through this process. We were really looking at what do we need to do within our programs to make sure that our students really understood the patient experience, that understood the healthcare delivery system, and would be able to work together and have an interprofessional learning opportunity that was more than this month you're going to be interprofessional. Because many of our programs we create an interprofessional experience. So in March you're interprofessional, and in April you're back in your own discipline. So we wanted to have something also for the students to be able to have a deep understanding.
I think we just had a virtual experience.
Yes. When I said deep understanding, I really
meant
didn't.
it.
I meant really,
Did you feel the
really
vibes?
deep. But to have an understanding about what it's like to take care of a panel of patients, what it's like to work in an interprofessional team. So we wanted also to have it with learners to start from the beginning. So we have in our program, we have a second degree entry for our advanced practice program in nursing. So we had second degree students coming in to the nursing profession. We had essentially second degree students coming into medicine. We have 2 pharmacy programs in town that we figured that having pharmacy was a key element to this. So we invited our pharmacy programs to join us with their students in their first year of pharmacy, and then social work. That as we were putting our academic team together, we thought there's a piece missing. And we needed to have social work, and we have a program that is also a second degree entry program. So we have what we call blank slate to blank slate. Nobody has been socialized in their discipline when they first come to this experience. That they haven't taken on the mantle of any one of them. So the program is the students spend 1 afternoon a week together in a clinic, and they will stay in the same clinic with the same team the entire time they're a student. So for medicine, it's 4 years. For pharmacy, it's 4 years. For nursing, probably will be near 4 years, as we would assume these are going to be our leaders, so they will probably progress from the master's into our doctoral program sort of seamlessly. And then our social work students will be there for at least 2 years. So they will have not only a deep understanding about working together as professionals, but also about the clinic and about the patients and about the clinic staff and what are the needs that we have. So we began looking at what did the student need to do. We created an immersion experience where we had them together. The focus was not on let's all get together and learn about being a team, but it was about how do we learn about the patients we're going to be caring for. So we have them go out in the community, we have them do what we teach all those others, what in nursing we would call community health nursing. We had them do windshield surveys of the neighborhoods, but then to really understand the people that were going to be the patients within the clinic systems that they were working with. So there's a little bit of didactic to this about patient care delivery, about quality improvement. So it's the foreground of this experience is all about new models of healthcare delivery. The background is learning to work as an interprofessional team. And I think that's the difference. We've tried interprofessional education at Vanderbilt several times, and we always put the focus on the interprofessional part. But we just turned that around to say, what are the needs of the patients? What's a contribution that each one of these disciplines makes? And what are the disciplines that are needed in order to give really good care in a cost-efficient manner? We're into our second cohort of students that started with us. So it is still a work in progress and a learning situation. But it has really been exciting to see students who are so committed to be with a client population for this long period of time.
Thank you so much, Lyndon. Certainly interdisciplinary education is so important to the quality and safety of improving patient care. So look forward to more dialogue with that. And what I wanted to also ask then is teen, because where teen is, nurses have certainly taken the lead in bringing both practice and policy changes to healthcare in both nurse-managed centers and through convenient care clinics. So, Teen, if you would give us some background about yours.
Well, good morning, everyone. And I got to tell you, it's like sitting in your living room. This chair is really comfy, so I just may take it with me on the way home. It's really delightful to be here. And since we're in Disney's own territory, I got to start with a quote. Because when we talk about nurse-led innovations, we really talk about dreaming. And if you can dream it, he used to say, you can absolutely do it. So we can all do it. Now, when we talk about innovations, and I think this is important, nurse-led or not, I think it's important to realize that you talk about a context of solving a problem. And both the retail clinics and the nurse-managed health clinics really address the core of what's going on in this country in healthcare at this point. We have a crisis of access. You heard that from Donna Shalala yesterday. And just some of the stats, let's be reminded about what this is about. We have about 50 million Americans that are uninsured at this point, another 30 plus million that are underinsured. We have people that can't get health insurance plans. We have about 12 million Medicare recipients that can't see a primary care physician because they're too frail. We have 70% of Americans, so many of us that if we call today a primary care physician and we need to be seen, can't be seen. So what do? We go to the emergency rooms. We have about a third of the Americans who tell us we can't get a regular source of primary care. And all of that is with the reality that we have a physician shortage in this country, and about 2020, we need 45,000 family physicians to provide access to care as healthcare reform comes into being, if it comes into being, and 30 million more Americans are insured. So that's the good news. The bad news is that we haven't prepared our workforce adequately. But I would say we have, and I would say the solution is all of you in this room. So I want to just sort of remind you about who coined the term disruptive innovation. How many in here know Harvard professor Clayton Christensen? Just raise your hands. A few of you guys, not enough of you guys. So part of your homework is to get the Innovator's Prescription by Clayton Christensen, and this is important. What he did, he coined a term around disruptive innovations, and what a disruptive innovation is taking a complex issue like access to care and providing simple solutions. And those solutions are nurse-led care. And the two ones I'm going to talk about are the nurse-managed clinics and retail clinics. They're disruptive, as I'm sure you heard Donna Shalala talk about, because what they address is really the core issues in healthcare, access to care, and they've really shown us that if you focus, nursing is the solution to some of these biggest issues we have in this country. Now, when you disrupt and when you innovate, you ultimately get some enemies because you're up against the status quo. And we cannot, deny then when we talk about nurse-led innovations like retail clinics, nurse-managed clinics, erupts in the faces of organized medicine. So we have to put that out there. But that's okay, because when you disrupt and people get uncomfortable, you're usually doing something right. And I think that's the tone of these innovations. And then I have to quote Disney again, because he said it's kind of fun to do the impossible when you can. So why does these nurse-managed clinics and retail clinic innovations work? You heard it yesterday. It's all about being accessible to the public, being affordable, providing a solution people can buy, and whether you're uninsured or not, and providing quality care. So I want to talk a little bit about the nurse-managed health clinics. How many here, I know you guys all know, but how many in the audience have heard about nurse-managed clinics? Raise your hands. Are good. All right. Not enough of you. So that means you guys haven't read the IOM report yet. So, Well, how many here have heard about Margaret Sanger and Lillian Wald? So they're really, I mean, when I think about nurse managed care, I think about those two amazing ladies that's all about nursing. What happened, I would say, the last 30, 40 years, we gave those clinics walls and they became nurse managed clinics. And what they took off in the early 70s when the role of the advanced practice nurses came into being, and particularly the nurse practitioner role, which was really a coup for nursing because it was a way for nursing to stand out there and say, guys, our friends in medicine, here's a provider, a nurse practitioner that can provide primary care. So nurse managed clinics is basically what they are. We have about 250 of them in the country and growing, but we don't have enough of them and we're going to need more of them. They take care of about 2.5 million people around the country. 1/3 of them are run by schools of nursing. Actually, Vanderbilt runs one of the largest networks of clinics. 1/3 are run by nonprofits in the country. They're accessible to the public. They're primarily serving a vulnerable population. That's who they've gravitated to. So you'll find them in underserved areas, in rural and urban areas, really where people live in impoverished areas. They provide primary care, health promotion, disease prevention services to people around the country. And what sort of distinguishes them from other types of practices is that nursing is in charge. Nursing runs the clinic, and the advanced practice nurse is in charge, and the nurse practitioner of the care of the patient. They provide integrated care, health promotion, disease prevention, behavioral health services, you name it, and they have a whole team. And that's why it's so great to hear that nursing more and more is really teaching in an interdisciplinary team, because that's what nurse managed clinics are all about. Now, in terms of outcomes, when you want to introduce a new model of care, you always have to focus on the outcomes, because you have to prove to your opposition, in this case organized medicine, that you're doing a good job. That's the way, that's the rules of engagement with innovation. And what we know about the nurse managed health clinics around the country is that they have high patient satisfaction, they have lower emergency room utilization, lower inpatient hospital days, lower prescription costs. You all know that means that they have cost savings to the system, so people like to hear that. But they also see their patients twice as often in the primary care setting. But primary care is all about seeing that patient, so that's a good thing, and we want to encourage that. Some of the challenges that comes with nurse managed clinics, let's be real, it is about nursing. And the fact is that, when you want to be financially sustainable, serving an underserved population, that's extremely hard in this country because we're not socialized. It is also complex because our healthcare system does not traditionally recognize nursing for reimbursement purposes. And that's an issue all of us in this room have to grapple with. And only half of the insurance companies at this point in time in the country actually reimburse nurse managed clinics and nurse practitioners. That's got to change too if we want to have a successful healthcare reform implementation. And then about the scope of practice issues that Donna and others talk so eloquently about. I want to shift gear to about 6 years ago, and this is important because this is the entry of the level of the private sector that noticed the role of advanced practice nursing. Why is that important? Well, some brilliant guys that were business guys said, okay, we've got an access problem in this country. Most people, even people that can afford care, can't get good care. And we've got these nurse practitioners out there that are very qualified, are primary care providers around the country. What if we marry, healthcare where people are, which is retail settings, with this qualified and awesome healthcare provider, nurse practitioners? And that became the beginnings of what we know of now as the retail clinics, and also known as convenient care clinics. What do they do? How many here have been to a retail clinic like Minute Clinic, Take Care? All right, a few of you guys. Not enough. You need to. That's the homework too. And there's many of them in Florida, by the way. So what they're about is accessibility, again, and affordability. They're accessible because they are run by nurse practitioners primarily. They're located in these high traffic outlets, easy to get to. They follow retail hours, so you can go and see a nurse practitioner there after hours. And I know you all have busy schedules, so it's hard to make healthcare fit your regular schedule. Appointments are you just show up, and you don't need appointments, and you can usually be seen very quickly. And the appointment's about 15 to 20 minutes. They're very affordable because the average cost is about $45 to $70. That may seem like a lot if you're uninsured, but with these clinics are really the lowest cost option that are unsubsidized by the government. This is all private market. And believe it, about 30% of people that come there don't have insurance, but they also do accept insurance, and that's important. Some of the positive impact they've had, again, very important. RAND Corporation, which is a large research institute, have studied them, and they have found that in terms of positive primary care impact. They really provide equal or better care to that of family physicians, no surprise to anybody here in the room. They're accessible to about a third of the population, lives within 10 minutes of these clinics, so talk about access to care. And they're also reaching a segment of a population that doesn't usually engage a lot in care, and I can attest to that firsthand. My husband goes now to the Minute Clinic near us, 5 or 6 times a year. Before that, he hadn't seen a family physician in 10 years. So they're really changing the way that people are utilizing healthcare in a very important way. So I want to sort of end with how things will evolve from where I sit, and I've had the pleasure to work with all of you and your colleagues around the country for a decade plus. And I think the timing is right for nursing. We're going to have more people insured, assuming healthcare reform really takes core in 2014. So we're going to need more access points. And that means that we're going to rely on all of you up here and all of you in the audience to really have qualified nurses that can help, take care of people out there. We also need greater prioritization of wellness and preventive care. And preventive care and wellness is all about nursing. So again, you're going to have to play an important role in that and how that's shaped. And more, these types of services will be reimbursed. So you're going to have competition, and think about that. And that's going to be something you want to think about in your schools of nursing. But the opportunities for nursing are really wonderful at this point in time. I think your time has come as a profession, and I think it's time for you to also claim that. A lot of the things that are going well in this country healthcare-wise, you have had a hand in. And I would say, one of the biggest things that are going on in this country is the consumer. The consumer is not the consumer we thought about 30, 40 years ago. The consumers want change, and they want an engagement with a level provider, that really what I call nursing care. And you're prime, to do that engagement with the consumer. So sort of with a little quote, ending again with a Disney quote, because I think that's, again, all when we talk about innovations, what this is about, that all your dreams can come true if we have the courage to pursue them, and I would say if we have the courage to pursue them together.
Thank you, Teen, and just remarkable comments and evidence-based work that's been going on here. And the point is the access to care, so certainly the changes have influenced healthcare out there. Cammie, and I'm sure the Nurse Family Practice Partnerships have done tremendous work also, and why don't you share some of that with us now?
All right, thank you so much. As you said, Nurse Family Partnership is based on the more than 30 years of research conducted by Dr. David Olds and his team of researchers out of the Prevention Research Center in Denver, Colorado. And interestingly enough, Dr. Olds and his colleagues are not nurses. They're not nurse researchers, but they've done some research to try to figure out what's the most effective way to meet the most vulnerable pregnant women in our society. What's the best way to meet their needs? And they actually discovered that it was through the deployment of baccalaureate prepared nurse home visitors. And through that research, Nurse Family Partnership was launched in 2004, so it's a very new organization. Our first full year of operation was in 2005. And since then, we have seen more than 1,300 registered nurses become employed in communities all over the United States to provide nurse home visiting services. Typically through public health departments, that's the typical agency. The relationship that NFP has with those agencies is contractual, kind of a franchise type relationship. Our focus is on trying to do what we can to make sure that the intervention is implemented as designed and with fidelity to the model. There are 18 model elements that we see as pivotal in this intervention, and as you can imagine, to make sure that variation in that intervention is as limited as possible is a daily challenge. But it is extraordinary to hear the stories of these women who have come to the program, come to the intervention, accessing health care very early in their lives, and really what is a fairly traumatic kind of experience that they're having, and to see them emerge as young professionals graduating from high school, community colleges, and even baccalaureate programs, and to see their lives transformed by the support that a registered nurse has given them is just really heartwarming. And it is an experience that I think is a tribute to what it is that nurses provide in the way of the art and science of nursing. It's the best of both worlds, and when it comes to the innovation, I think NFP offers nurses who provide this service autonomy in a way that is unique to many other practice settings, flexibility. Certainly the client focus, as you've both talked to, is pivotal, as well as being a healthcare professional who is interdisciplinary in mindset, because tapping in to the services that these young women need in their communities is just important to help them navigate their way through pregnancy and in the first 2 years of their first child's life. So it's just really heartwarming to see nurses do that all across the country, tapping in into those community resources. It's prevention and wellness focused, and hopefully sets the mom on course to really have a life as a mom and professional that she wouldn't have had otherwise. I actually was in a home visit. I experienced a home visit, and this mom that was in the program was about a year and a half in. She was actually not working, on drugs, and homeless. She's now living with her mother and grandmother, had completed her GED, and was offered scholarships by 12 metro area community college in the Denver area. I mean, that is just extraordinary. She was considering her options. So that was just really great to see. But it is something that I think really brings the science of our discipline and the art and care of our discipline together in ways that are really unique. When it comes to leadership opportunities for nurses, I'm an example of someone who's been given the opportunity to lead in a way that otherwise I wouldn't have been able to have. Nurse home visitors typically can advance to be nurse supervisors. Nurse supervisors around the country are finding their way to program director positions and even to state health department leadership commissioner kind of roles. At the national office, we have a lot of staff that we've recruited from the state level to help us as either program developers to help communities establish and launch these NFP interventions, and we have nurse consultants who are master's prepared nurses who work with agencies after they've launched to make sure that operational efficiency is taken care of. As you know, there's no new state or federal dollar available for any great intervention, and so we have to find a way to work in this current context. They also make sure that clinical practice is as we anticipate it to be, and they really are champions for quality improvement. And so they're really working with agencies in their regions all across the country to make sure that that lives are transformed and communities get the return on investment that they're promised when we introduce nurse-family partnership to them.
Wow. Well, what a story with particularly our mothers and babies, and not just care, but care.
Right.
Much to change individuals. Thank you very much. And Bev, I know that you have something to say on this, so why don't we do it?
Okay, Madam Chair and my colleagues, one of the things that the NLN has figured out is that whether you're talking about nurse-managed clinics or whether you're talking about the wonderful nurse-family partnership or the innovation of interprofessional nurse education, health education, but putting it in the background and not the foreground, I think that's fantastic. It all takes leadership. And so my little contribution is a story about leadership. In order to talk about the future, I'm going back to the work of a genius, Edgar Allan Poe. It's the story of the descent into the maelstrom. And many of you might have read it at some time if you're a fan of Edgar Allan Poe, but it's going to be told from a Bev Malone perspective. So, you know, Edgar may be rolling over in his grave about how I'll use it. If you want the beautiful prose, though, go to his book, or it's a short story, a very short story, but full of, I believe, relevance to leadership. It starts with an older man. We used to call them old men, but now that I'm older, we call them older men. And a young boy that are sitting on the top of a precipice, and you know it's really slick, and the young boy is kind of afraid of sliding off, but overlooking a sea in Norway, and they're just sort of watching the water, and it's a very turbulent kind of water. it may appear calm at times, but then before you know it, it's whirling, and there appears whirlpools in the sea. And the older man is saying, I have a story to tell you, to the younger man, that about that sea. I was in that sea. Me and my brothers, we were fishermen, and we were out and about fishing. And we would always be careful to stay away from the times when the water was turbulent. We knew the waters. But one day we went out, and for whatever reason, we were coming back a little later than usual. And we got caught in a horrendous storm. There was a hurricane somewhere about, and we thought it was over, but there was an aftermath to the hurricane, and the water, before we knew it, went from calm to totally ferocious. My brother, one of my brothers, immediately was thrown into the sea by the waves, and I lost my brother that way. That left two of us, and we were struggling to stay afloat and to stay on board the ship. My brother and I were very close together, and my brother tied himself to the wheel, to the stern, because only one of us could be tied to the stern, and I pulled away so that he could be tied. And I just held on. And as I looked, as we crested and the waves were moving, I could see that we were headed toward the maelstrom. We were headed toward the whirlpool, toward the vortex. And before I could think about it, we were there. And we were going round and round in the vortex, down and down. And every time I looked down into the abyss. You know, Edgar Allan Poe, it's always the abyss. And it was just destruction. And I was so frightened about that. He said, but it was also magical and wonderful. And every now and then this would come into my mind that I was privileged to see nature at its worst and its best. And he said, and as I realized that I was not attached to anything, and I was kind of floating around, that I started to look more up. And time just kind of stopped, and I noticed that the things that were spherical, they tended to sink into the vortex faster than the things that were cylindrical. And I just kept looking up at the majesty of this storm, and it suddenly came to me that maybe there was a way that we could get out of this. And so I tried to talk to my brother to tell him to unleash himself from the stern, take it off, and tie yourself to one of just the barrels, because it tended to rise. And I kept looking up because barrels were going up, and everything else was going down. Ships, I mean, there was a Dutch ship that went down, and we were not too far away. But my brother refused to untie himself from the stern. He felt safe tied to the stern. So I tied myself to a barrel, and I found myself going up and up and up. And before I knew it, I was on top of the sea. And colleagues of mine picked me up from the sea. And you see this white hair that I have? It changed in a matter of that day. I used to have very black hair, and now jet black hair, and now immediately it was white. But I survived. And the lesson, colleagues, about leadership, for me, looking at that incredible story that Edgar Allan Poe presents as a gift to all of us, is you got to keep your head up. You got to look up, even when this incredible storm is happening. And I know that if any of you are in leadership, and my colleagues here on the dais, there's no way to lead without being in storms. We just gave an award to Billy Brown, one of the captains of storms. I know there's no way she could have done all the wonderful things that you've done, Billy, without storms. And so the question is, are you going to focus on the abyss? Are you going to keep your head down, looking at your own destruction, lost in you and the destruction? Or are you going to look up and see the context, the system, what's happening in the rest of the world? And are you going to develop a taste for chaos. I believe leadership, you got to develop the taste. You've got to say, good. A little chaos never hurt anybody. And I believe you have to untie yourself from whatever your stern is. Whether it's that we have to educate our students in lockstep, it has to be a schedule and it has to go like this. She had to untie that whole, that was a stern. Or whether it's that, can nurses really run these clinics and will we be accepted by the public and how do we do that? And people are saying negative things about us. That's that stern, you have to untie yourself from it. And the nurse-family partnership, of course, nurses know that we are the best prepared to go into homes with new moms and to work with them and before they have their babies, including after they have their babies. But someone named David Olds had the guts to actually do the research to show that we are the best at doing that and making a difference over years and years, and that nurses are leading the way in that. We have to buy that. We have to understand that and own that. So to me, the story says leadership is about untying yourself from whatever your stern is. Leadership is about the dreaming that Teen talked about. It's about dreaming, and the guy who was in the vortex, he had to be doing some dreaming because life didn't look so good. So you have to look up and look around and do that dreaming and own it, that there's another way to survive. There are all kind of possibilities. That is, for me, what leadership is really, really about. And I acknowledge my colleagues and their brilliance and their abilities to make these things happen. But my story is more about Edgar Allan Poe and a taste for chaos and an understanding of how you let go, how you look up, and how you float to the top.
Thank you, Bev. And Edgar Allan Poe will never be the same for me. Great. But I want to ask our innovative leaders to consider the models that you have and talk about some skill sets that may be needed by nurses who work in them. So specifically, what type of competencies are needed for those who work in these settings? Linda?
Well, I think from the students and then graduates who are going to work in this interprofessional world, they have to have an understanding of what the contribution is that they make to the healthcare, but also to understand what the other disciplines do. And that's been a real aha experience for the students, but I have to say the faculty have had more of an aha of, I had no idea that's what pharmacy did. I really didn't know physicians did that sort of thing. I think as nurse educators, we have to be really willing to untie ourselves to some of the language that we've found offensive. We have, medicine is going to call it medicine no matter what, as opposed to health care. We try to clean up language and say that we're delivering health care, we're not delivering medicine. Well, does it really make a difference? We're all in here to take care of patients, whether you call it medicine or health care. So I think really getting over that thing of feeling like we have to have nursing in the name of what we're doing may not be something that we need. So being able to have that openness and willingness to say, we're going to look different, our education programs are going to look different. And the other, I think, key learning that we've had with this interprofessional program is that it has to be a required part of the curriculum. It can't, whatever you're doing, and we're piloting, but we're taking a required part of our curriculum and having the students do their clinical in this way. And all 4 disciplines found that until we came to where it was required, you were replacing, you know, one kind of clinical with this interprofessional experience, the students didn't value it, nor did sort of the clinic group. So it's got to be, in order for this to be successful, we've got to be able to be open to different other ways of teaching and to figure out how this becomes part and parcel of what we do, not an add-on.
Thank you. Team.
Sure. So I sort of have this image now, you know, the vortex. I'm looking up in this barrel, and I would say that think about this barrel as a toolbox, because I think it's easier if that barrel is armed with something, and that's the reason why it can flow to the top, and that's knowledge. And I think what we're seeing and that is needed in, especially with nurse practitioners, advanced practice nursing, but I would say it's all on nursing, is business skills. And I don't know where that starts, but it should start from day one. Healthcare is about money, and this is about power. And whether it's nursing or medicine, and it doesn't matter, but if we understand money and power, we will understand how to lead, and I think it'll be a freeing experience. I mean, yes, take care of patients. That you've always done that as a profession. I'm not sure we talk and feel good about talking about healthcare as money, but it's all about that. So what do you need in that toolbox, that barrel that Beverly talks about? You need business skills. You need to know how to run a business. Healthcare is about running a business, and taking care of people is running a business. You need to understand the politics, because otherwise you get surprised. And I would say nursing has taken a longer time to get where you are today, and I would say your time has come. So no worries, you're there. You're at Union Station in Washington. You just have to accept and say, wow, we're there, and all look up. But the reality is that it took you longer, because I'm not sure that toolbox, that barrel, was filled with political skills. And I think I'm not sure it was taught, but that needs to be taught from that day one, when that school nurse, future nurse steps into education. Because if you understand those two things, healthcare, taking care of the patient, is easy, but you're armed with the right pieces to be brave enough to look up and get out of that vortex.
Thank you. Cammie.
Jen, I agree with you. I really believe that while nursing curricula can't go on for an extended period of time, and certainly to not compromise on the clinical leadership, research aspects of our education, somehow to try to integrate those business principles that Tim just talked about, organizational development, finance, being able to understand those concepts, accounting, be able to follow the money from where it flows from the government throughout an organization to customers, that sort of thing. And that's just pivotal in the work that we do. All those governance principles that are at work in both for-profit and not-for-profit organizations, we've got to have a better understanding about that. Strategic planning, business planning, those sorts of principles are just pivotal. I have found myself in my professional career going to the business literature as much or more than the nursing literature to try to figure out how to work through something. And so it's the area that I have found myself wanting for walking around knowledge, so to speak. So I've really tried to immerse myself in that literature so that I have the skills that I need to make decisions in the moment. Forecasting, predictive modeling, all those statistical, analytical activities that really need to be done. Economics, how do we as nurses communicate to communities what they're receiving because they're making this investment in a way that's compelling. The other thing I think we need to really work into our frame of reference, and it has to do with politics, that is, we have to be able to speak to all political parties. If we do that, the nursing, the health care of patients, the health of this nation will transcend from administration to administration to administration. To the degree that we have really integrated ourselves with one party, I believe to a certain extent over time it works to minimize us when that party is no longer in power. One of the things that NFP did was really come into national prominence under two Republican administrations. President the first President Bush actually acknowledged NFP and had a line item for investment in this program in his budget. And of course now Barack Obama is a champion for this program as well. It has really worked to the benefit not only of NFP, but to vulnerable moms, families, and communities all across this nation. That is a key that we have got to get a hold of.
Great, great. Thank you. Bev?
Yeah, well, you know, I think in your toolkit and in your barrel, you should be doing some dreaming, especially if you're in a vortex. You got to do something while you're there. But I don't think it's easy to dream. I don't think we get permission to do it. I think it's something that you need to build into your schedule. I think you need to have some scheduled time for not thinking. And that means that usually good things are happening when you're not thinking, when you're not trying so hard. It means that the creative juices have space, because I think that we are the best to-do people in the world. Folks love to hire us because we will get it done. Give us a list, we will do it. But there will not be any time for that unhinged kind of floating through thinking. And that's the dreaming piece. So I think that that's a real part of creative leadership, transformational leadership. The second one is understanding boundaries. You need to know where you start and you stop. We cannot be everything to everybody. It would be nice. I'm not even sure it would be nice. It's a little overdone that we try to do it all by ourselves. So you have to have some idea of where your boundaries start, even if you're talking about with your clients, with your patients, with those that you're providing care for. There are boundaries between you and that family, that patient, those students, and we need to understand what our boundaries are, acknowledge those, understand how to manage boundaries. The third one is that we need to have an understanding of systems, that if you don't figure out that you're in a system always and you need to know what system you're in and what level of the system you're operating, you got a problem. Someone said something about multi-pronged something to me the other day, and yes, it's multi-system level interventions that we need. We need to intervene on more than one system level. So, to me, that would be a good start in your barrel.
So living with uncertainty, embracing it, moving forward. Thank you so much. Now what we want to do, and you've heard the skill sets, some ideas about some characteristics and skills that our graduates need to interface in these innovative models, not only interface, but to thrive and do well. So what we want you to do is come to the mic and let's start talking. When you come to the microphone, please keep your remarks brief, no longer than 2 minutes, so that we can hear as many people as possible. And of course, please state your name and school. Is there anybody at the mic? Anybody coming to the mic? And I see somewhat, I see several. Go ahead.
I'm Shannon Perry, and I'm retired from San Francisco State University. And just to increase or add to your analogy, Bev, cream rises to the top.
All right. Woo.
Thank you, Shannon.
I'm sure Edgar Allan Poe would appreciate that one too.
Next.
I'm Pierre Broadnax. I'm the director of the nursing program at the University of the District of Columbia. I found that in your toolkit, you need to have clarity of vision and a very, very thick skin.
Thank you for that advice. Yes, sir. And then back at the next mic. He was there first, yeah.
I'm Stephen Patton. I'm president of the National Association of Clinical Nurse Specialists, and my day job is I'm a perioperative CNS at the Portland VA Medical Center in Portland, Oregon. Okay, whoa. My name's Stephen Patton. I am president of the National Association of Clinical Nurse Specialists. My day job is that I'm a perioperative CNS in Portland, Oregon at the VA, and I teach part-time there as well. One of the things I want to talk about is that we want to also look at the other advanced practice nursing roles. CNSs are very active in primary care, as well as the nurse midwives, so we want to make sure that we include those as well. I think yesterday when Donna Celaya said that we're 3 million strong, we better act like it, I think we do need to find how we come together as 3 million. In my 25 years of history in nursing, I've recognized that we divide and conquer ourselves almost on a daily basis, and we need to stop doing that. And I appreciate NLN's bringing groups together and being inclusive as opposed to exclusive. So thank you.
Thank you, Stephen, and that's why we have chosen that value specifically. Yes, ma'am.
Hi, good morning. I'm Michelle Moulton from Baltimore, Maryland. I teach at Hartford Community College. My question was, how are schools of nursing, undergrad and associate degree, currently with their students, collaborating with nurse-managed clinics and retail clinics? Are students attending clinical there? Because I see that we continually have barriers in the hospital settings, and as faculty, we're reaching out to community settings, which I think is great because that's where all the prevention's happening. But I do wonder, are these nurse-managed clinics going to make an environment and support schools of nursing to collaborate together?
So great question. Yes, so both of them, can you all hear me? So I think it's on now. Let's take the nurse managed clinics first. And I want to also, address Stephen's point is that, I didn't really talk about who works in nurse managed clinics. Most of them are actually very faculty driven. You've got nurse practitioners maybe in the helm of primary care, but you've got a team of clinical nurse specialists, so a lot of specialty from clinical nurse specialists. So, it was amiss not to mention that. Midwives as well work in the clinics. And then you've got RN, BSNs, and you also got medical assistants and other types of providers. But from the nursing perspective, because they're so rich with really all the disciplines of nursing, you have faculty members and students that have opportunities to work in those clinics. That's why 2/3 of all of them are run by schools of nursing, because it is their own laboratory, for service. So it's a great way to, to actually get your students and also faculty members have a faculty practice to do research and so forth. Mm-hmm. We also have had an influx of federal funding, not enough, and especially not enough in this environment, from Division of Nursing that has invested in those clinics to allow the faculty members and students to get an experience. Moving on to the retail clinics, there's a lot of interest. There certainly are more on the advanced practice level opportunities for nurse practitioner students that want to practice there. But they also do a lot of prevention and education. So what we are seeing with our large members is really, faculty and practice arrangements now with schools of nursing where students can rotate through them. And I would say a lot of faculty members practice, on the side in those clinics. I mean, the joke I always get is that a little email from one of our colleagues around the country says, "Teen, I'm toe dipping in the clinic. I'm moonlighting." I says, "You're not moonlighting. This is your practice, and you're making money, secondary to your university. That's a great thing." So lots of opportunities in those markets. And there's also leadership opportunities, especially in the retail clinic market. The two largest companies, which are Take Care Health Systems, that's owned by Walgreens, and Minute Clinic, that's owned by CVS and Caremark, the two nurse practitioners that are over the nursing profession has an incredible experience, sort of oversight. Both of them have about 1,500 to 2,000 nurse practitioners under them. Think about that. That's like an army. But I don't know anywhere else where, nursing will get that kind of leadership role. And both of them that run that are, women that are awesome and really folks we need to look up to, and people we need to write about, because they're changing and transforming the way that leadership is being done. But great question, lots of opportunities, and we can create more. And that's why I'm delighted to be here.
Thank you.
Great response. Thank you.
Elisa Mobley, Robert Wood Johnson Scholar, Rutgers State University of New Jersey. My comment has to do with, you mentioned the relationship to access to care and the knowledge that nurses need in terms of business. I want to relate it to what Dr. Shalala said the other day regarding the high deductible insurances. I met a woman with one of those HMO insurance cards. She has a $5,000 deductible, and you're not allowed to collect a co-payment until they've met the deductible, which you don't have any idea of whether they've met it or not. This is something that's going to affect the nurse practitioner run clinics. It's something that's going to affect private practice. You have patients coming in with a true insurance card, but with actually no payment and no funding that's going to go with the billing that you send out to them. Are these the kinds of things that are being incorporated into nursing education for our advanced practice nurses?
Take that.
You know, I think that's something that is in an emerging part of what we're doing in advanced practice programs. I think all of them have some content related to healthcare delivery, related to financing for healthcare delivery. I think we all need to be sort of charged with making sure that we have these new emerging types of reimbursement systems included in our programs. I can't speak for all nursing programs. I know from our corner of the world, we try hard to address all of that, but I think you bring up a challenge that we really need to make sure that as we're working with this portion of our curriculum, that we make sure that all of the types of reimbursement is something that we address, and then help our advanced practice nurses figure out how they're going to survive in that kind of environment.
Thank you. Bill?
Yeah, I just wanted to speak to the issue of you can't teach everything, you know, and that when you teach a systems perspective and you teach that you have to explore and you innovate and you really delve into the area that you're working with, then there's an expectation that we as nurses will get our baselines together in our academic programs, but then we will continue to learn once we leave those programs, and we will have to make sure we get to those courses that make a difference, make sure that we do our own preparation, and have that open mind that says maybe there's more than one thing happening here. How can I figure that out? Or who do I need to talk to about this is a new area for me? Who's been in that area for a while? So I don't want to give the idea that we can teach everything, because I think that's been a real binding issue for faculty, that the idea that you have to teach it all. And at least in my program where I came, they really tried. I mean, and I felt like, and my colleagues who we were graduating with, we felt like that they had tried to put everything they could into the curriculum, and we held it against them. So it's yeah. So it's just too much sometimes to try to fit it all in. The question is, do we know how to think? Do we know how to evaluate a system? Do we know how to look for further information? Do we know how to collaborate with colleagues who know more than we do? Do we have a mentor around? This is a new area for me. I'm working with patients that I haven't worked with before. I need a mentor maybe like Teen. I need a mentor maybe like Cami. I need one like my president, Kathy Schultz, or one like Linda Norman. I need a mentor who can sort of help guide me to the things that my program didn't teach specifically, but I have enough of a searching perspective, a searching kind of behavior, an understanding that I will never know it all, but I will be able to relate, negotiate, collaborate with others who know more than I do at the time, and give the best care possible for the patients that I'm taking care of. The other thing I just wanted to say is that the first role I had after my master's preparation was a clinical nurse specialist. It was the best role of my life. It prepared me to deal with people forever. And I think that there's no better preparation than a clinical nurse specialist preparation.
Thank you. Next, please.
Hi, good morning. My name is Leila McKinney. I'm a campus president, dean of nursing with Chamberlain College of Nursing, also a family nurse practitioner. And it was mentioned a bit earlier by the gentleman who came up, and I just wanted to probe a little more. We know that it's our time, and I think we're all being called to strengthen our profession and come together, and yet we have a reputation for being segregated, and I'm not sure that's completely unfounded. And so I'm wondering, you know, in a time where we have multiple professional organizations, credentialing agencies, certification agencies, all servicing and soliciting the same population, what we can do as individuals and educators and leaders, and what these organizations plan to do to lead by example in terms of coming together and strengthening our numbers, because I think it can be beneficial to us as a group to do so.
Thank you.
You know, the one thing that comes to mind of a time that nursing recently has come together is with the APRN document. That when you look at the list of organizations that came together to really look at what should the shape, the practice of advanced practice nursing, what should it be? I think that's an example of a time that we really have come together, and hopefully there are going to be some more opportunities for us to do that.
And I would add that where there has been more and more come together, particularly following the IOM Future of Nursing report, and most specifically, you could even go on NLN's website and see where that togetherness visibly has occurred, and particularly at the tri-council level, to actually, in the first time in the history of this country, place a academic progression model as something that all of those organizations support. And there have been more and more and more of those activities, primarily within the last 2.5 years. So they're out there, and I think that leadership is doing that, and I think that it's been very positive for us. So hopefully it set the tone for the rest of the country. Bev, did you have anything else to say? Okay, Cammie?
I was just offer that from an enterprise that relies on nurses to deliver services. We actually experienced the coming together and support of the nursing community that really made a difference at the congressional level when we were leading a home visiting coalition to try to get an allocation of $1.5 billion into the Affordable Care Act for evidence-based home visiting. We had nursing organizations, national nursing organizations, sign on to those letters of support and engage in those advocacy activities willingly. And to me, it's a lesson in what can happen when we as a nursing community put our best efforts toward problem solving, making a difference for clients, for patients, for students, and that sort of thing. So that's at least a microcosm of what can be. And if we'll do more of that, I think we'll be better off as a profession because of it.
Thank you. Teen?
And I would actually argue that, I followed you as a non-nurse, in the nursing profession probably now 15 years. You're more together than I've ever seen since I started. And I think that's an important message. I think the Institute of Medicine report could not have been written. It was ready to be written. And that was really the culmination of the groups working together. That doesn't mean everybody's always going to agree. And there are times when pieces of nursing has to step forward because it's the right time and you should have to gauge the right moment. So you also have to allow yourself to sometimes allow in advanced practice field a nurse practitioners group to step out versus the clinical nurse specialist versus the midwives versus the the nurse anesthetist, whatever that may be. So part of that, and that's sort of figuring out how we all work together in that toolbox. But I will also say, more importantly, in addition to nursing coming together more, is who's actually joining you, and that's what excites me. The private sector. You had all, the retail clinic is a phenomenon. I used to have a friend that would tell me, a mentor, that would tell me, Teen, if you could put the nurse managed clinics on the main line in Philadelphia. Now, if you know the main line in Philadelphia, that's the Mayflower folks. That's where all the rich folks live. And her thought was, if you could show what all the wonderful things that happen in a nurse managed clinic to somebody who has money, who has power, you're really going to take this show on the road. And really what happened with the retail clinic model was the private sector, seeing, wow, here's a profession, here's an idea, let's marry them, and let's, figure out how we actually make it part of mainstream America's healthcare. And that's what they did. And I would say once you have these other power players, whether it's hospitals, business taking an interest in nursing as a general, you really have arrived. And that's why I think we've seen a lot of pushback from organized medicine and other places the last few years, because they really realize that your time has come. So I would say that, it's okay, it's good to say that we're working together because you are, but I would also say that now we have to push forward and bring all the other sort of friends in the fold, because that's what it's going to take.
Thank you. One last question.
Good morning. Pat Hinton Walker. I'm Vice President for Policy and Strategic Initiatives at the Uniformed Services University in Bethesda, and I'm also interim chair of the foundation. I'd like for us to think just a little bit out of the box. We frequently talk about, as we have this morning, adding content and we already know we have a crowded curriculum. Part of the League's focus has been evidence-based education, and so I'd like for us to think about borrowing evidence from the science of emotional intelligence. So I'll put my coaching hat on for a second. And what we know about emotional intelligence is that it's really 20 to 30% of what our knowledge base is and whatever our science or discipline is, and 70 to 80% emotional intelligence. And today you've been talking about two of those competencies, one being personal power, and the other one is organizational and political awareness. And in my work with nursing faculty as well as nursing students, we find that the research is consistent, that women tend to be scoring lower in personal power than men and higher in empathy. And so one of the things we need to do is not necessarily add more content, but think about how we change that culture and use the science and the assessments that are already out there to think about how we might change the way that we work and approach it. And so I think it's a culture change, building on Donna Shalala's point about how we move this power that we have forward. And I think there are some tools there that we can think about. The last thing I would say is that one of the things we know for women, use of personal power, is they skip over assertiveness and move to aggressiveness, and that works against them. So I just think we need to think out of the box and not think about adding, but perhaps a different way to approach it.
Thank you. And at this time, I ask our panel members to... I'm sorry, is there... Oh, sure. I didn't see her. I thought, I didn't know there was another at the mic, sorry.
Thank you very much. I'm Dorothy Otto from the University of Texas Health Science Center at Houston School of Nursing, and during our process of SACS accreditation, we formed a campus-wide ethics committee with our 6 professional schools and the faculty representative from each of the schools. And what we have done is created case studies using schools in the professional setting. I did the first one. Of course, nurses can always write cases. And it involved an individual who had 4 molar extraction and was later diagnosed with acute leukemia. And so we had the nurse, the dentist, and the physician. And what we do is we share our cases written by each of the faculty members on the committee to discuss with their respective students. And it has become a very meaningful experience with each of the professions. Our schools are, of course, the School of Nursing, the Medical School, Graduate School of Biomedical Sciences, School of Public Health, and our latest one is Biomedical Informatics. And we're each developing our cases collaboratively and including representatives from the schools. Thank you.
Thank you, Dorothy. So at this time, to finish, I would like each of the panel members to give some closing thoughts and words of wisdom to the audience. Thank you. And Linda, let's go here.
Well, I think we've got to really look at what are the innovative things that we can all do within our nursing programs to make sure that we are helping our students meet those, be ready for the healthcare system. You know, certainly we think that interprofessional care is a part of it. There are lots of different ways to be able to do that, but I think we need to figure out how that can be part and parcel of what we have within our curriculum.
Thank you. You're right.
So I think, I mean, another thing we need to look at is sort of emerging markets. And I keep telling that to my colleagues in the nurse managed clinic field. I keep thinking about the aging, the baby boomers and so forth. And I'm not seeing a lot of us teaching to the opportunities. It's going to be a huge market. And how do we incentivize, you know, some of our nursing students to go into those fields? Elaine has taught me over the years, there's not a lot of interest. We got to change that. And I think part of the mindset, going back to that business thought process, is that if we, educate and teach to the opportunities that are going to come at the horizon, I think, again, nursing can continue to stay in that leadership role when it comes to really shaping healthcare in the future. And with all that said, I look at all of you and I see an exciting future in nursing, and I go back to what Walt Disney said: if you can dream it, you can do it. So keep on dreaming and keep on doing.
Thank you. Cammie.
I'd just like to ask that for those of you who have members of Congress who sit on the Super Debt Committee, the group that is working on the debt ceiling crisis, if you'd be sure they know who you are, that they see you as a resource, because as nursing-related programs come up for discussion for potential cuts, especially if they're discretionary programs, it'd be nice for those congressional representatives to have nurses to call and talk to about whether to support or oppose that recommendation. I would ask for that same request as it pertains to the $1.5 billion in the home visiting portion of the Affordable Care Act. Right now, and it was created as a mandatory funding source, but mandatory funding sources are going to be on the table if in fact the Super Debt Committee can't reach a compromise, and it doesn't look like they're going to. So as a nursing community, it's time for us to be sure that we're communicating our legislative challenges with each other and really relying on each other to help provide support across the country. And so we'll be sharing our legislative alerts as those come up with organizations like the NLN, and would invite NLN to do the same for us. So together we can really try to minimize the reductions that we see in nurse-related funding programs.
Thank you. Bev.
I would just say that acknowledge each other's innovation, creativity. Nurses, we are some of the most creative people in the world because we keep our eye on the patient. We keep the patient out front. I think our creativity comes from a need to deliver care and services under really strange circumstances, under really difficult circumstances many times. And so we get creative in the process. And I don't know if we acknowledge that creativity. Pat Hinton Walker talked about power. And I think that that's a huge, huge issue for us. It takes power to create. And so, check out your own power base. How are you doing with your power these days? Make sure that you acknowledge one another. There's no reason not to really love being a nurse and love being a nurse educator.
Thank you. So in closing, I want to say that this esteemed panel has given us much to think about. And what they've done is spurred some wonderful ideas from their experiences, but also sharing invaluable information that you can't get in any one place. And these are leaders who've done so much within their locality and nationally. The words of wisdom are for us, and not only is it information, but it's also hope. I heard skill sets. I heard don't be afraid. I've heard vortex. I've heard hope. I've heard be, create, and power. So what you've seen is a blend from both this panel and you, the audience. And all of you have just contributed so much to us as nurse educators. I want to thank all of you for the thought-provoking issues raised and for your engagement. You are indeed the voices of nursing education. And as your button says, as NLN members, you help to advance the nation's health. We've got to remember that. For those of you whose questions were not answered today, there will be another opportunity at the National Faculty Meeting tomorrow morning and at the town meeting on Saturday. Thank our colleagues, please. Wonderful. And before we disperse, I have some announcements and reminders. First, Dr. Malone will deliver the CEO Summit Address in this hall tomorrow morning at 8:30. You don't want to miss that. Immediately followed by the Centers of Excellence and Research Award presentations at 9 o'clock. Then after a short coffee break, for which we thank the sponsors and 11 current Centers of Excellence in Nursing Education, Dr. Judith Halstead will preside over the National Faculty Meeting. And as you know, there are many lunchtime activities at the Summit. However, please remember to pick up your box and these box lunches, and these are in the exhibit hall prior to going to any of the events. Box lunches will not be in the rooms, only in the exhibit hall, and you do have your little tickets to pick those up. Tickets for the NLN fundraisers, Blue Man Group and Arabian Nights will be available for pickup or purchase today and tomorrow at the on-site registration desk. Thank those of you who have already purchased, and there are still tickets available. We really hope you'll do these. This fundraiser funds go to the National League for Nursing Foundation, which provides invaluable resources to nurse educators. And lastly, I'd invite you to stop by the NLN booth and visit with the members of the panel to share further your thoughts and ask questions. And please enjoy the summit. Thank you. Have a good day.